Good evening. Let's continue. I'm Dr. Nguyen. I'm a gastroenterologist and I'm an advanced therapeutic endoscopist at Mission Hospital. And I wanted to talk about pulmonary condition, asthma, which is fairly common. If you follow the series of talks, we focused a lot on common conditions like gastroesophageal reflux disease and what is the therapy out there. So this is a spin on a topic that we've covered in the past if you've been following our series. If you haven't been, hopefully this will be something new and exciting. And if I'm being repetitive from prior talks, I apologize. It's just a very common disease. So is there a correlation between asthma and gastroesophageal reflux disease? And this is what we're going to talk about today. See if I can advance the slide. So Laryngopharyngeal reflux, or LPR, it's a second condition, is similar to gastroesophageal reflux disease, and we think this can be related to Gerd, but patients have more upper symptoms, whether it be a cough or hoarseness. If you look at the center of the slide, 10% of the visits to a head and neck doctor or ear, nose, and throat doctor are related to LPR, this entity of upper symptoms related to acid reflux. And oftentimes it's underdiagnosed. And patients go on and they suffer, and the diagnosis is difficult. And if you're looking at the top, 50% of the asthmatic cough and wheezing were reported in one series at the bottom of my reference to be associated with Gerd. So Gerd is gastroesophageal reflux disease. 30%, about 30% of the patients with LPR and voice problems also experience heartburn. So you have heartburn, which is Gerd, and then you have LPR. So is it the heartburn causing the LPR, or is the LPR unrelated to the heartburn, or is it partially related? Of those patients who have LPR, half actually have daily heartburn. So not just episodic heartburn, but symptoms that they have on a daily basis. LPR, again, laryngopharyngeal reflux, is present in at least 50% of the patients with voice disorders. So you're talking, again, very common conditions. And we look endoscopically, more than half of these patients don't have anything. The esophagus looks normal, and they have symptoms, and we have to have further workup, and oftentimes the workup is not readily available, or it's something that patients don't know about, the physicians don't offer. And then patients go on, they suffer with these upper symptoms of cough and hoarseness for years. So that's the introduction. There's a little bit of a different spin than what we talked about. I think I skipped a slide. I'm so sorry. Why do we care about Gerd, and why do we care about LPR? So, you know, we have a little bit of heartburn, some acid reflux. Why does it matter? And this is why it matters. Esophageal cancer is a huge problem. It's on the rise, and we see an increasing incidence over the years that we've tracking this tumor. And the number of cases have grown 600% compared to 1975. And this really deadly disease is the fastest growing type of cancer in the US currently. And that has to do with again, that common entity, Gerd. When you chart it in the middle chart against all the other cancers, it really trumps out. Here you have at the bottom in red lung cancer, melanoma, but it by far greater than any of these cancers that we compared with, breast cancer, colorectal cancer. And along with the incidence of disease, of course, we know there's a very deadly cancer. So we care. We care about GERD. GERD, the acid reflux can change the lining of the esophagus over to a precancer condition called Barrett's esophagus, and then on to cancer development. This is an esophageal cancer at the bottom. And GERD, you know, the typical symptoms we talk about are heartburn, people get chest pain, regurgitation, they have a little bit of bloating in the epigastric area. They can have problems sleeping, some sensitivities to certain foods and liquids. So here at the top of the atypical symptoms of GERD is what we talked about, the cough and the sore throat and the constant clearing of the throat. You know, our patients sit there in our waiting room waiting to be seen, and they're constantly, you know, clearing the throat, and we can identify which patients in the waiting room have a component of GERD or LPR. Hoarseness, so all these things we talked about. Asthma. So there's been series in the literature looking at the association between GERD and asthma, COPD, interstitial lung disease, chronic lung conditions. And not an uncommon evaluation for a patient undergoing a lung transplant. We have to do a GERD evaluation. So that just tells you that GERD is really, you know, it's in the picture. As you can imagine, whatever is coming up from the stomach into the esophagus, it can go into the lungs as well. So dental things, dental erosions, bad breath, gum disease, and then the ear and nose discomfort. What are the anatomic causes of GERD, and why do we have GERD, and why do we have LPR and asthma? It's a mechanical failure that occurs at the bottom of the esophagus. And so on the top structure here, you'll see that the bottom of the esophagus, there's a muscle, and that muscle is called the lower esophageal sphincter. And that sphincter muscle is closed, except when we eat, and the sphincter will open and the food goes in, and then it closes back up again. The diaphragm is a set of muscles. It's like a dome, and it separates your chest and your abdomen. And the stomach should be below the level of the diaphragm in the abdomen, and the esophagus in the chest, above the level of the diaphragm. Okay, so that's a normal anatomic structure. The failure and why GERD occurs is all these problems here. Patients develop a hiatal hernia. So the hiatus is the opening of the diaphragm. And a hernia is part of the stomach above the level of the hernia up into the chest. And that's the slippage of part of the stomach. I hope you can see my arrow, where the stomach is slid up into the chest above the level of this diaphragm. And the hiatal hernia being with the stomach above reduces the function of the sphincter mechanism that holds the stomach contents in its place. And also in the chest, you have negative pressures, and in the abdomen, you have positive pressures. So the pressures are different. And so the stomach sees negative pressures when it's in the chest. The angle of His is the angle between the esophagus and the stomach, and it's more acute in patients without any symptoms, and it becomes more obtuse when patients have GERD. Patients with GERD also experience what this is called transient lower esophageal sphincter relaxation. So intermittently, the sphincter relaxes when it shouldn't, and you're not eating, and that's when reflux occurs. Other things that hold the structure in place, there are ligaments that hold the structure in place, and as time goes by, as you age and we eat, some of those ligaments get broken, and it's associated with GERD. So as I talked about, there's a lower esophageal sphincter, that's one. And then the other one is this green, the diaphragm that holds the stomach acid in the stomach. So there are two sphincter mechanisms. So GERD and GERD spectrum disease, here it shows you that you can have milder conditions, you can have more severe conditions, and we intervene and we treat based on the severity of the condition. So earlier on, when you have milder conditions, we talk about, lifestyle changes. You eat smaller meals, you avoid the certain foods in life that increases GERD, like tomatoes and wine and caffeine and citrus foods and chocolates. So it kind of lists everything that's good in life, and it increases GERD. So earlier on, when patients have milder symptoms, we talk about lifestyle changes, avoiding foods, eating smaller meals, not sleeping so late at night. As we progress in the disease and you have more symptoms, we discuss with the patient about medications. So pharmaceuticals, or the medications that are available, are many different types of anti-acid medications that control the acid in your stomach. So when you do reflux, it's not acid that you're feeling, but it's the regurgitation of non-acidic contents. So when we talk about LPR and asthma, some of that may be the non-acidic reflux that is causing the trouble that we have. And there are different mechanisms other than the direct acid effect. So when you treat a patient with LPR or asthma, it takes a little bit longer. It's more difficult to treat because it may not be the direct acid effect. So when it's the direct acid effect, you have the heartburn, you take the anti-acid medication, you feel better pretty soon after you take the medication. But for other, like the more atypical symptoms, the anti-acid medications, if it does work, it may take a little bit longer. And sometimes we don't see results until, 3 months into medication use. So as we progress into more severe conditions, we have endoscopic therapy, we have surgery to fix the problem or fix the GERD. So of the patients who suffer from GERD, we're talking millions throughout the US. Very few, less than 0.1% of the population, actually undergo intervention or treatment to treat the condition traditionally, just because surgery is difficult, it can be associated with complications. And now with the advent of endoscopic procedures, I believe more patients are considering intervention for GERD. So we talked about the medications to suppress the acid. So the simple medications like anti-acid medications, Tums, Maalox, you take it as needed. Doesn't work that well. You just kind of pop it when you have symptoms. And the next level, the higher, the stronger medication would be an H2 blocker like Pepcid, Tagamet. Zantac was recently pulled off the shelf, so that's not available anymore. The PPIs are proton pump inhibitors. They're the strongest anti-acid medications, and these are like, they're mostly over the counter. They can be prescription. They're, for example, Prilosec, Protonix, Prevacid. So those kind of medications you take on a regular basis. They're not as needed, and they suppress acid. So one thing that's important is that it's not an overproduction of acid in your stomach, but your stomach normally produces a normal amount of acid for digestion and its function. But when you take, when you have GERD, it's not an overproduction of the acid, but it's just the acid coming up into the esophagus and into your lungs. So as I said, Zantac was available for a long time and many decades. The FDA now ordered the drug to be pulled off. This was a few months ago, not a month, a few months ago from the market due to risk of cancer. So PPI have a lot of side effects. So patients sometimes don't realize, and now a lot of people are reading about it and more concerned. There's a lot more in the media about it, and it's becoming an issue because you read about it and you say, okay, how much of it is real? And patients often come in, they're on a PPI for 20 years, and they thought it was not a drug without side effects. And there's been published in the literature, everything, it goes from dementia to cardiovascular disease and micronutrient deficiency. And I think the two most believable or a little bit of science behind it would be kidney disease associated with PPI use, and then increased risk of osteoporosis related to chronic PPI use. There's a recent study, and I think this is important, the era of COVID is showing an increased odds of having a positive COVID test in patients who take chronic PPI versus those who don't. This actually makes sense, I think, because your stomach, again, needs to have acid to do its job, to have its function, again, in digestion and so on, that now you're shutting it off. So it makes sense to me. There was also a study recently that came out looking at chronic PPI use and increased incidence of colorectal cancer. So a lot of different things. Some of it is maybe true, maybe an association, maybe causative, but there is a concern out now for chronic PPI use. So before we do intervention, diagnostic testing for Gerd includes an endoscopy. So an endoscopy is where we put the scope in a little tube with a light, and we take a look at the inside lining of the esophagus. And here we look for complications of Gerd, like esophagitis or inflammation, stricture or narrowing of the esophagus, Barrett's esophagus, what I talked to you about before, which is a precancer condition, or any kind of other anatomic abnormalities. So an upper endoscopy is usually the first line in terms of diagnostic. At the time of endoscopy, we'll usually place a little capsule, and it's called the Bravo, and it checks for acid reflux. So it performs an ambulatory pH test, and it looks at acid in the esophagus over a 4-day study. So during those 4 days, we have the patient avoid taking anti-acid medication because we actually want to see what's refluxing. And we document acid reflux. We look at upright supine reflux. We look at correlation with symptoms. We look at the severity of the GERD or the acid reflux. This on the left looks at the function of the esophagus, and this can also often be done at the time of endoscopy, called endoflip, where we look at the motility of the esophagus, make sure the esophagus is pumping things through normally. An X-ray study, sometimes we also do have a patient would swallow a little bit of contrast, and we'll take an X-ray picture to look at the anatomy. Is there other diagnosis that can mimic GERD? What does the esophagus look like? And this will also look at motility or the function of the esophagus. This is a typical pH study. This is what comes back after the patient returns the monitor, looking at acid or measuring pH in the esophagus. And here you see a pH of 4, and anything that drops below the pH of 4 represents a reflux event. So this patient had a lot of daytime refluxes when the patient slept, and during the sleep or the supine periods, the patient had no reflux at all. So this is a positive study suggesting the diagnosis of GERD with symptom correlation. So whenever the patient said there's heartburn, it correlated 100% with a reflux event documented on the pH study. So I talked briefly before about the endoscopic technique, the endoscopic fund application. So it is called TIF. So it's transoral incisionless fund application. So it's an endoscopic technique without surgery that we can create a valve that acts like a flap valve endoscopically, and it decreases acid reflux. So this is a modality available for the treatment of GERD. So it's non-invasive, incisionless, no surgery. There have been many studies, long-term data out available, many procedures, thousands of procedures done throughout the US. It is a treatment modality that covers the gap between patients who are on medication when they want to get off the medication, or they're on medication still have symptoms and they don't want the surgical intervention for a GERD. It's covered by many different payers, Medicare, HMOs, and endorsed by many surgical and GI societies. So briefly, this is a schematic of what TIF is. It's a device we place into the stomach, and we bring it back on itself, and there's a scope inside this black tube, so we can actually visualize what we're doing. So it's a full thickness, sorry. I'm sorry. Okay, I just lost it. Okay. Sorry, I'm having a technical thing here.
No worries.
It's not coming up. Okay, let's see.
We can see it now.
Okay, now we're back. Sorry, I a little equipment issue here. Okay, so in the middle at step 2, can you see my slide now?
Yes, we can.
Thank you so much. So step 2, we pull the tissue into the mold, and fasteners are placed similar to a suture to create a plication. Somehow I'm not seeing my arrow anymore. You see my arrow? Okay, I lost my arrow. So to the right at step 3, what you see is a 3-centimeter valve, and it's a 270-degree wrap. So the wrap is not complete. So you don't have any problem swallowing. There's no problem burping or vomiting compared with the traditional surgical intervention called the Nissen fundoplication. So there you have a complete 360-degree wrap, and often, not often, but patients can have problems swallowing. So with this TIF technique, it's just enough to prevent reflux, but it's not too tight that you don't have any problem swallowing. So it's a beauty. It produces that balance between just enough of a valve to not have problems related to too tight of a wrap. So the many studies out there, initially we looked at sham-controlled, randomized controlled trials, all showed that it was effective. We have 10-year data and information. So the TIF evidence, there's a lot of studies out there showing that it's effective. 5 systematic reviews, randomized trials, many cohort studies, and 140 publications with many unique patients and long-term follow-up. So here you see at baseline, patients improve their quality of life. And looking at a score, this is a GERD quality of life. And when you see at 1 year symptom improve, the symptoms stay improved at 3 years and 5 years. Here's an elimination of regurgitation. So that's important because when you take the anti-acid medication, again, it cuts the acid, but it doesn't prevent regurgitation. So a fundoplication done endoscopically, as you can see here, you can eliminate the symptom of regurgitation. So food doesn't come up, whether it's acidic or non-acidic. And looking at, again, 1 year, 3 year, and 5 year persistent symptom improvement. Here looking at the atypical symptoms improved up to 5 years. So the atypical symptoms are other than heartburn and regurgitation that we talked about. I'm going to skip. I was going to share a patient's story. Here you look at, I'm looking at more objective data. So after TIF, we want to see how many patients get off their proton pump inhibitor. Of course, nothing is 100%. So if you look at all the studies and you compile all the studies together, and you come up with an average about 81% across 11 studies with greater than 6 months follow-up and more than 500 patients. So you're thinking, well, why is it only 81%? Why is it not more? And this, I think some of the studies are looking at complete cessation of PPI. So in patients who were on anti-acid medication, they require less anti-acid medication, they counted that as a failure. For to me, that isn't a failure. You were on less medication, so that really is effective. So the studies are either on or off PPI. So that's why, you know, you're seeing that number, but it's probably greater percentage of patients who are on less PPI use, with less PPI need. So to the right, you'll see patients that improved esophagitis or inflammation. That's more objective information. Here we're looking at pH score, so that Bravo test pre and post. And so effective, how effective is TIF? Of course, you improve heartburn, regurgitation, quality of life. pH studies are normalized. Decreased need of PPI use. And of course, TIF is superior to PPI use in eliminating regurgitation. Many meta-analysis, many studies show that we can reduce a small hernia, eliminate PPI use in more than 85% of the patients. Okay, this is a little too detailed. I wanted to share this story. It was memorable for me and for the patient. He had Barrett's esophagus and high-grade dysplasia and nodules in the esophagus, so severe Gerd. I had kept him on PPI chronically. I took away some of the nodules endoscopically, and we did radiofrequency ablation of the Barrett's. So high-grade dysplasia is the next step to cancer. So he had really severe, nearly cancer. And we had ablated it. We ablate the Barrett's, but he had persistent disease because he kept refluxing, so the acid kept coming up. So we decided to repair his hiatal hernia and TIF. And subsequently, after the hiatal hernia repair and TIF, we saw resolution of his high-grade dysplasia and then complete resolution of his symptoms. So that was a fairly memorable case. The patient's very grateful. This shows durability. This is an example of a patient who had TIF, and it's an immediate post-procedure, and you can see the black tube is the scope. We're looking back on ourselves, we're in the stomach, and you can see a little bit of blood and the valve. And the picture to the right is what the valve looks like at a year. So very similar. This shows that whatever we create before, it looks very similar. And of course, at 5 years, we also have 5-year data showing that the valve looks similar. This is to show that patients with a larger hiatal hernia, we can fix the hernia. I'm trying to unmute myself, but I can't unmute, but unvideo, turn on the video. Okay. So in patients with a 2-centimeter hiatal hernia or longer and a Hill grade 2 or more, the Hill grade is the width of the hiatal hernia. If it's a large hiatal hernia, what we'll do is a concomitant hiatal hernia repair and TIF, and this shows its effectiveness. So the hiatal hernia repair is a robotic approach. We bring the stomach down, we bring the diaphragm together, we repair the diaphragm. And at the same time, we'll create the valve, that second sphincter, and we do that TIF valve endoscopically, and the patients are, this shows effectiveness of the CTIF. Chelsea, I can't turn on my video. I'm trying. I'm not sure why.
That's okay. I tried to push it for you to turn it on and it doesn't look like it's working either.
Yeah. So, improvement after hiatal hernia repair and TIF. Side effects, adverse events, usually after fundoplication or hiatal hernia repair and fundoplication, we admit the patient overnight. It's an overnight stay. Patients go home. They're on an altered diet for about 6 weeks. Minor symptoms of chest discomfort, shoulder ache has been reported. Side effects are minimal perforation. Anytime we do an endoscopy, there's a risk of perforation. The last one we had related to TIF was from 2008. The device has been well perfected and complications are not common. So here is our side effect profile compared to them over the many years. I think earlier complications with smaller experience, as we get to do so many of these procedures, we get better at it, and of course complications are low. Indications for TIF, as we covered before, patients with symptoms despite PPI use, patients on PPI chronically who want to get off PPI because of the side effects of PPI, patients with an abnormal pH test, and esophagitis, patients with Barrett's esophagus, afraid of getting cancer. Contraindications, usually in the literature, they report that patients with higher BMI, more obese patients, of course, patients with esophageal stricture or limited neck mobility, prior gastric resection can be a contraindication. Thank you. Thank you. Bye-bye.
Thank you, everyone.